stool real quick. Oh, wait, no, I don't, because it's on the end. We're good.
All right, go ahead then.
Okay, hi, guys. I'm Danny. This is my patient, and I'm here with McCall and Megan. We are Indiana State's doctorate in athletic training students. We are first years. Today we're going to do some opening and closing muscle energy techniques at the cervical spine, and then Megan and McCall are going to do OA and AA mobilization techniques. So the first ones I'm going to do is the opening muscle energy technique. So if they have pain, it's going to be kind of hard to see because you can't see my hands, but your hands kind of go like this, right into the occiput.
Okay.
And so this is for when they have like a stiff neck. So if they're like wake up and they have a kink in their neck and they can't look all the way, you place your hands like these. And you move away from the side of the pain. So if they're having stiffness in the right side, you're going to laterally flex them away from the side of pain, and then rotate their neck towards the side of pain. And then you take that your left hand and you place it on their cheek, and you tell them to actively try to push into your hand. So, yep, just like that. Do it for about 5 seconds and relax. You go into more rotation until you feel that resistance, and then you have them push again. Okay, and relax. You do that about 4 times, and then you put them back into neutral.
So are you providing overpressure?
When you go back into that, so you rotate them, so you're here, and then you rotate them this way, and so you go into that, you can't see me.
No.
You go into that, what's it called? Range of that they're able to do, and then once you find the stiffness, that's where you do the mobilization with movement. So you have them, or muscle energy. Then you have them push against. You hold that for 5 seconds. Once you hit that 5 seconds, then you go into that overpressure again. So it's just kind of constantly try to push them a little bit past what they're used to.
Yeah. So, because me and Megan both want to try it, we're just gonna alternate here.
Okay.
I move you back.
I think you just
rotate.
you just turn my head.
Okay.
Yep, and then perfect, just like that.
Okay.
So no more. You don't do more lateral flexion. You just do more rotation every time, right?
Yes.
Yes. Okay.
Yeah.
Cool. All right.
And this one is going to be called closed. So the only difference between these is the open one, you go away from the side of pain, and in the closed, you go towards the side of pain.
Okay.
So open and close is in laterally flex. So you have your hands under the occiput, you go towards the side of pain, you rotate their neck away from the side of pain, and then again have them do that pressure, good, again, or relax, and again.
I can definitely feel my neck loosen up. So, are your hands doing anything particular underneath, or it's just supporting? Are they in a certain spot, or?
You support it right underneath the occiput, and you kind of give it like just a slight amount of neck flexion.
Oh, okay.
Yeah.
Okay.
Cool. Have you ever used this, or any of us have we ever used? I've never used
Not
this in
really.
my practice. But.
No, I've actually had it done on me back in grad school, but I kind of forgot about it since then.
Yeah. Well, just when McCall was practicing on me, I felt like my neck, even just going when she over pushed a little bit, it moved more after I.
Yeah, I've had one done where they put the pressure similar to what you guys are going to show. They put the pressure on the transverse process and then did muscle energy, so they kind of combined both.
Yeah.
But it's interesting to see them separated. So.
Yeah, absolutely.
All right, so I'm going to just move on to what Danny was just mentioning. OA mobilization technique, which just also stands for occiput and atlas mobilization. So this is when your patient is having stiffness and tightness at the top of her base of her neck. This can also be used as an assessment tool and then later on as a treatment. So when you're first using it as an assessment tool, you're just looking to see if there is that tightness or if there's maybe even extra laxity there. And then if there's tightness, then you would use this as an actual treatment. So you're gonna put your fingers together like this, and you're gonna find the first transverse process on the neck, which I was just gonna call it's hard. It's kind of hard if you're not used to it. Okay. Okay, and then once you grab those and hold those tight, you're going to then, so with your right hand, you're holding on to the atlas, and then you're gonna, with your other opposite hand, you're gonna move the neck up and down. And so then right here, I can feel if she's having some tightness or resisting. And then as a treatment, you're just gonna do little flexion oscillations. So just kind of moving those up and down while you're still holding that atlas in place. Relax, there you go. And that is that.
So this is for what, like I said, you use the METs that I showed for when they're stiff, like looking, but the one that you just did would be stiff in flexion, right?
Yeah, stiff and flexion.
And extension, or mostly just flexion?
I want to say mostly flexion, but it would glide that joint, so it would probably help with extension too.
Okay.
It's a little hard to get a feel for it.
But do you feel like that's
Yeah.
the right spot? So then C2 would be there.
Mm-hmm.
So basically, you're stabilizing that vertebrae,
Yeah.
that cervical vertebrae, C1, and moving everything around it, right?
Yeah.
So for
Makes sense.
C1, you're doing the transverse processes, and then for what you're about to explain, it's the spinous
Oh,
C2.
right. Okay. So for the next one, it's called the AA mode, meaning atlas and axis. So you're gonna find the C2 spinous process. So there. And you're essentially doing the same thing. So you can, this can be used evaluative. You're looking for stiffness, and then you can use it as a treatment if you're finding that. And you can also put them into some side or lateral flexion, side bending, however you want, and do the same movement. You can move throughout the range. So again, with that, your right hand, or whatever hand you choose, is going to be on the spinous processes of C2, and then you kind of use your forearm to rest the head, and then you take your left hand on the dome of their head, the base of their head, to kind of move it. So you can go through. All right. Any questions with that?
I think that's good. I think an interesting point is if someone has long nails, this would hurt them a lot.
Yeah, right? So you kind of have to keep your nails trimmed.
And also another point, like I'm a bad patient because my muscles don't relax. Like when you're doing reflexes, I don't do that.
Right.
So I think finding a way to make sure your patient understands that they need to stay as relaxed as possible to make sure you get the best out of the treatment, or most out of the
Have
treatment.
you found any success in getting somebody to relax that long? there anything
I
in
usually have them
particular?
squeeze their hands or focus on something else because it kind of makes them take their mind away from the actual area you're
Sure.
working on.
I've used this one. The only time similar is actually in a mobilization with movement. So I pinned those transverse processes, and then they moved them themselves.
I see.
And I've used it both in rotation and in flexion. So similar idea, just without them doing
Yeah.
it.
Right.
I think to get just more comfortable with it just takes a lot of practice on finding that placement of your fingers and where you want it to be.
Have you guys used it, McCall?
Not really. Not like any of that. I to be honest though, I've not been in situations where I have a lot of neck issues, and if I do, it's more of like, okay, I massage them, and that seems to help. Like it's never anything particular. A lot of upper trap stuff and trap things with swimmers I've had, but I think I'm gonna start using this because probably a lot of their issues has to do with neck, with breathing to the side and stuff. But I just didn't. I knew some of this, but didn't feel confident enough to use it, or it didn't come to my mind. So.
And I've seen Greg use this before at my clinical practice, which is the guy I work with. And then also I usually do a lot of passive joint play, but I think me moving them into motions will definitely help with gliding more.
Yeah.
Are you with swimming, McCall?
Yeah.
Okay.
Mm-hmm.
Yep.
Yeah.
So like in theory, they should have a lot of neck issues, and we do here and there, but nothing particular. We have a lot of rib dysfunction. Like I've had a lot of issues with that, or even like posterior, but I've had a couple anterior rib dysfunctions where I've used some muscle energy to relieve that, but
Interesting.
not a lot of actual neck pain. You know what I mean?
Mhm. Yeah, I used it more when I was in the physical therapy setting. So they came in with like car crashes and stuff, and then we'd use it.
Right. Yeah.
Mhm.
I can see that.
Cool. Well, Danny, if your patient wants to leave and not listen to our conversation, she can, but I know she's an AT, so she needs to also follow along.
Thanks, Bree.
No problem. Thanks, Bree.
What a nice coworker.
Nice to meet you guys.
Yeah.
Nice to meet you.
Yeah.
Okay. We have a few more questions this week that he wants us to discuss and put into our document. So I figured we could go through that, and we can add comments here and there as we want. As we're talking, we can type. But.
Okay.
Did you get my Google Docs that I sent you?
Yes.
Okay.
It's open right now.
I was telling McCall, I was like, Danny's the best note taker around.
I just type really fast.
Yeah.
No, you're impressive.
I'm really slow. I'll be like typing, like, can you repeat that? Wait, go back. 3 bullets ago. Wait, what?
Okay, so what are the questions that we are aiming
So the
at?
first section, we can each add a little bit if we want. It's just kind of comments from the group, or helpful hints that, we can talk about when you've used it and whatever. But the section 2, he wants to know a little bit more about our typical evaluation process of the cervical spine. So what does the group think the components of a good C-spine evaluation is?
Range of motion and posture.
Yeah, definitely. For me, it's like posture. I can always tell.
Yeah.
And I'm like, no wonder you have neck pain, because your head is 6 inches in front of your body. Or range of motion, being able to go through.
Yeah.
Now, do you see significant limitations with, a football player compared to a softball player?
Because of muscle mass?
Yeah,
Or-
muscle mass, and because at least from what I see here at ICU, which I don't work directly with the football team, but all of them, they do muscle, or they do strengthening, specific neck strengthening in their strength and conditioning programs. And so they all have, I think, limited range of motion because they have built up so much of their trap and, neck muscles. Do you see that as a limitation, or I don't know?
Working out of high school, I know Danny, you work in high school too. My football athletes, or at least at mine, they are not fully committed to strengthening that neck, and a lot of them have not as much muscle mass as you would expect in a football player. So I don't think I've seen too much difference in that. But when I'm doing my range of motion, I guess for an evaluation, I'm looking at mostly what is causing that most pain. So flexion or extension, so I can kind of get a grip on what the injury might be. But
And definitely palpation. You want to feel if there's a rotation somewhere in the C-spine.
yeah. So, but I think you would definitely see that more at a college setting where.
But under muscle mass, I put and maturity of the body, because depending on your setting,
Yeah.
Yeah, absolutely.
Right.
And female versus male, or just development, right? So I don't. Some people have longer necks. I feel like I have a really long neck as compared to the big stocky guys that you feel like have no neck. It's all. I think I have a lot of range of motion compared to maybe that guy who would have a lot more limited.
I think neck range of motions are hard because, you know, if you're looking at the shoulder range of motion, you compare bilaterally, but
You
with
don't
the
have
neck,
anything.
you have that one thing to kind of go off of, so you don't know really how limited they are.
And I always find, like, every time I have someone with C-spine, I mean, I work with high schoolers, so Meg, you might get this, but they're just like dinglings. They're like, they come in and they're like, when I go like this, it really hurts. Why are you doing that? Like,
Cheating on tests or
yeah, I just like, sometimes it's so hard because, you know, people sleep so weird. And so then maybe they're like just rolling their neck when they wake up and they're like, oh, in this spot, it hurts.
In this exact moment, right
Yeah.
when I do this.
it's always. I think I slept bad last night.
Yeah.
Oh my god,
Yes, you did.
probably. What are you sleeping on the floor?
Yeah.
Okay, so what special test do you guys usually use? I can't remember the last time I did an actual neck evaluation where I used a special test, so I'm a little weak in this area. But
Only ones I literally ever use, more so because I've never seen anything worse for the C-spine, is, I don't even remember what they're called, but you compress them when they're straight and then you side and then you compress.
yeah.
That's just to rule out anything like significant, because normally they come in, like you said, sleeping bad. I'm like, well, you didn't get a fracture like that, so.
Right.
Yeah.
Sometimes, what is the one where you like drop their head into extension? They're laying on their back. They drop their head into extension and turn it.
Vertebral artery.
Yeah. So I've done that. I think.
Done that?
What?
You've done that?
I think so. I'm
Yeah.
not sure why I was doing it. I don't think I knew why I was doing it.
I've done it because my professor in undergrad stressed so hard on if you're doing a cervical evaluation and if they're having major issues with it, then test that and see if they have that first rib or vertebral artery.
Oh yeah, and and thoracic outlet kind of is related in that form. So
Yeah,
I think,
that's first rib and scalings.
yeah. So I've done a little bit of that, but that's about all.
I think I've done compression and distraction, and you know, if I think if they're complaining about some numbness down like one limb, you know, I kind of try to get them in that stretch and see if that Spurlings will kind of.
Furlings, that's what it is.
That's it. Yeah.
And then I've dealt with a lot of neck injuries.
You have?
Yeah.
Good. I'm glad you're in this.
Yeah.
I need to learn.
So kind of just like feeling around on making sure everything's in line. And then if one, like I had a girl who her C3 had so much laxity in it.
Yeah.
So just like making sure like joint play. And when I was doing that one, I was lucky that our team doc was around. And so he saw that and he suggested she got like x-rays and stuff. Nothing ever came from it, but she just ended up having a very mobile or hypomobile joint.
Yeah.
So.
And brachial plexus thing, so nerve pathology.
Yeah. And then,
Okay.
yeah, I guess like my biggest thing is with most injuries is history, and then
Right.
figuring out, you know, if it's more bony, is it painful at extension because of the spinous process, or flexion and rotation with herniation or something.
Yeah, I agree. I'm definitely more cautious, and I think I'll do maybe, I'll palpate around, and then I'm like, okay, if it seems like something specific, I almost always refer, because neck is hard and it gets like really tricky. It can get tricky fast.
Yeah.
Okay, so the next question is, what are you looking for? We kind of talked about that already. What are you trying to rule out? So fracture,
Yeah.
nerve, right?
Mm-hmm.
Hernia.
Yeah, like disc issues.
Yeah. I think a lot of times with neck injuries, if they're having a lot of, like, especially with high school students, which I know we've mentioned this like 3 times, but like if I'm palpating on their spinous process and they're like, ow, that hurts, and then automatically as a clinician, you're like, whoa. But then I really make sure to like go all the way around it and say, okay, I'm right next to it. Is it the ligaments that I feel like are sprained, or is it actually like the bone?
Yeah, so that's hard.
Always do the, like, if this is the spine, you press 1, 2, which one's worse, 1, 2.
Yeah, right. And it's hard with high school kids, a little bit that I've worked with them. It's like everything is the end of the world. And so I have to decide, okay, is it musculature? Is it on the outside or is it right in the middle? Is it on the outside? And I say, does it hurt when you touch it here, or does it hurt when I touch it down the middle? That kind of thing.
Yeah.
Mm-hmm.
They don't always get that.
They don't always get a lot of things.
You're right.
I love high schoolers.
Yeah, they are kind of cool.
They're
though.
so pretty.
They are something else.
Okay, any tips or tricks, any questions that we might have for Dr. Powden?
Oh, I was just doing one evaluation the other day for a, I think she does shot put and discus, and she just started this year, and the coaches have been doing a lot of strengthening, and she was kind of complaining of some numbness right here and some like pain on her neck, and I did those nerve tension tests on her, and I got a really good one with her. What is that?
That would be. That's
the pinky. Well, I'm ulnar.
ulnar nerve?
Yeah.
Yeah, ulnar.
But I've just, because I think sometimes you hear numbness and tingling and you kind of like, and especially with neck pain, you kind of freak out. But a good thing that one of my docs told me is like, if it's a serious C-spine, you're looking for numbness and tingling on both sides. And if it's on one side, then continue to do a very serious evaluation, but then look further beyond. Like, is it the posture? Is it, some kind of nerve tension that they're having? So
Yeah, that's good.
Yeah.
Anything you got, Danny? I don't really have.
I've been writing these down. Are you guys open on the docs right now?
Oh yeah.
Yeah. You're doing great.
Do it.
That would have taken me like 50 minutes. So just.
What about just our usual thought process? So obviously you're gonna go through like critical, right?
Yeah.
You're gonna look at the critical injury first. Is there a fracture? Is there any significant damage? Do you need a C-spine? Like that kind of thing. And then from there, like you said, moving outward.
Yeah.
So is it something happening in the scalenes, and that's why the numbness is happening? Or
That's like one thing.
Have you guys ever done? What I do a lot is positional releases at the neck.
yeah.
That seems to, because a lot of neck things cause headaches, and then you go back to like the root of the headache, and they're like, oh, whatever. I was stressed. I was tired. Whatever it is. And then scalenes. It always comes down to scalenes for some reason. And then the first rib. So first rib and scalenes are kind of my number one thing at the neck.
Yeah.
And the SCM.
So when you're working with scalenes, what do you usually have do or have them do?
I do a positional release if they have like tightness there. Positional releases like all day, and then I'll release the SCM just in case. And then more than often I'll do muscle energy at the cervical.
Yeah.
Or not muscle energy. I keep saying it. Mobilization with movement.
Oh, okay, yeah.
Yeah, you were talking about that a little bit earlier.
Yeah, so like I pin and then they move.
Cool.
And I think one thing I was just talking to with one of my students is, sometimes mobilizations and stuff can be painful for the patient, or making that movement. So just as a clinician, taking the judgment of, yes, this will probably help them, but is it worth putting them through that pain right now as they're so inflamed, and then wait a couple days to do it instead?
Yeah, that's true.
Yeah.
All right.
Can you discuss any readings? Or
not in this.
No, I don't think so.
Perfect. I was just going to say, because we were talking about how tension headaches, and then just one of them, they were talking about how extension is a good sign for a different source of a headache than other. But I never thought of that as an evaluation technique. I'm just like, oh, you have a headache. Like,
Yeah.
Where's it at?
Right.
But not range of motion to put them through. So.
Cool.
Yep.
All right. I think
Do you guys want to add anything else on this document?
that.
Or anything more specifically?
I think the only thing that we need to add is he said, any bulleted points from the groups about the actual
Technique.
techniques that we did. So we can like each add a couple points per person over the next day or something and then submit it.
Okay.
That's okay with you guys.
Wait, have any of us used these actually?
I had not used any of them really. I've done a little bit of like where you hold and push.
Sure, like general,
Yeah.
but not.
Yeah.
I've learned some of the muscle energy techniques, but I don't think I've actually ever used them on a patient. I do first rib quite a bit, but yeah, that's fine. Yeah. Okay.